Afternoon, everyone. We're just going to give it one more minute just to allow a few more colleagues to join us, and then we will get started. Okay, it's 2 minutes past on my clock, so I suggest we get started. I'm sure we'll be joined by further colleagues as we go. So thank you very much, everyone, for sparing the time to join us this afternoon and potentially giving up a big chunk of your lunch break. I promise you it will be worth it. We've run quite a few of these webinars over the last few months, focusing on the newer weight loss medications. Some of those sessions we've very specifically focused on the dietetic or psychological elements that go alongside the medications. But today, once again, we're going to switch back and very specifically focus on the medications themselves. And we're going to focus on Tirzepatide, which is the new kid on the block, so to speak, and very much a hot topic at the moment. Next slide, please. So I'm Neil Gupta. I'm medical director at Oviva. I'm a GP in London by background with an interest in type 2 diabetes and obesity. And alongside working for Oviva and being a GP, I've spent over a decade working in NHS commissioning and was previously the chair of a CCG in North London. And that commissioning experience will be specifically relevant when we come on to talk about what NICE has had to say about these medicines, and also when we talk about how you can help your patients access specialist weight management services. But actually, I've got the easy job today, and I'm joined by two fantastic colleagues, Shane and Wasim, who will be doing most of the heavy lifting, and I will let them introduce themselves when we come to their sections. We're going to aim to finish around 12:45. We do have the Q&A function running, so we're going to try and leave a few minutes at the end to take questions. So if you do have questions, please do pop them in the Q&A section. If we run out of time, we are very happy to respond to those questions in writing. Okay, just a quick word about Oviva, because I'm sure there are a few people on the call who are not familiar with Oviva and what we do. We provide services for people living with weight-related conditions, so primarily obesity and type 2 diabetes. And that includes being part of the National Diabetes Prevention Programme, being part of the National Diabetes Remission Programme, which is the so-called low-calorie diet programme, and specifically relevant to today, it includes the provision of Tier 3 weight management services in both England and Scotland. What makes us slightly different is that we provide the bulk of our care remotely. So that's through telephone or video appointments or digitally through the Oviva app. And as opposed to more traditional face-to-face in-person appointments. What's really important to stress, and what I always stress, is that we only deliver services within the NHS. So we don't have any private direct-to-consumer self-pay weight management services. Next slide, please. And this slide just gives you an idea of our history and our coverage, but focusing specifically on Tier 3 services, we've been delivering Tier 3 weight management services in the NHS since late 2017. And in that time, we've had well over 15,000 referrals to our Tier 3 weight management services. And about approximately 3 years ago, we embedded the use of GLP-1 medication into our Tier 3 weight management pathways. So really the aim of today's session is to hear from two of our experienced tier 3 doctors who are going to share their knowledge around these newer weight loss medications, but equally importantly, they're going to share some of their first-hand experience of using these medications in the real world. Because as we know, as GPs, we are regularly seeing people coming to us asking for these medications, or actually what we're seeing in a lot of instances is people are already accessing these medications in the private sector and they're looking for support. But many of us, and I would have previously included myself in this, many of us will have received next to no training in the management of obesity previously. So the aim of the session is that you come away feeling better equipped in having those conversations with patients about these treatments, even if you're not actively involved in delivering that care yourself. Next slide, please. So a brief section from me to start, and I'm really just going to go through a whistle-stop tour of what NICE has had to say about these medications. And I think it's important to recognise that we've been using GLP-1 based therapies for some time, at least 15 years, for type 2 diabetes. And the weight loss benefits were appreciated very early on, but it wasn't until Saxenda, which is liraglutide, that one of these medications was specifically licensed for use in weight loss. And Saxenda was approved for use in the NHS for weight loss in December 2020, having been licensed some years before that. And the criteria that NICE outlined for use were very restrictive. So you had to be living with obesity, you had to have pre-diabetes, you had to have elevated cardiovascular risk, and it had to be prescribed in a specialist weight management service such as a tier 3 service. So as a result of those very restrictive criteria and also some global supply issues, very few people actually had ever ended up accessing Saxenda through the NHS. Next slide, please. The real game changer, as I'm sure everyone knows, came with Wegovy, which is semaglutide, mainly because it was so much more effective than Saxenda. But also NICE approved the use of Wegovy in the NHS in September 2023, and the criteria, the eligibility criteria, are far more inclusive. So it was quite broad. You have to be living with obesity and you have to have any weight-related comorbidity. And the point about all of these bits of guidance is that NICE puts them out through what's known as a technology appraisal. And a technology appraisal has a very specific legal status within the NHS constitution, which means that if you are a patient in England and you meet these criteria, then you are legally entitled to receive that treatment through the NHS. And that is very distinct from some of the other outputs of NICE, such as clinical guidelines. So we have clinical guidelines for asthma, for heart failure, for hypertension, which have no legal status whatsoever. The challenge was that alongside those clinical criteria, NICE also stipulated that people needed to access the treatment only through a specialist weight management service, such as a tier 3 service, and therefore imposed a maximum duration of treatment of 2 years. Next slide, please. So the problem, as I think everyone on this call will appreciate, is that there just are not very many specialist weight management services out there in the country. We know that access to tier 3 services is generally poor and it's hugely variable. So it is the classic postcode lottery. And we can look at that just purely through the lens of Wegovy eligibility. So around that time when Wegovy was endorsed for use in the NHS, NICE estimated that there are 4.2 million people eligible for treatment with Wegovy. But around the same time, NHS England estimated that there were only 35,000 places in tier 3 services across the whole of England per year. So you have 4.2 million versus 35,000, and clearly that is a very significant mismatch between the need in the system and the capacity in the system. And there are lots of different reasons for that, but really at the core of that is our retrograde attitudes towards obesity amongst decision makers in the NHS, and really a failure to see obesity as a long-term condition that merits treatment as per other long-term conditions. Next slide, please. Okay, and this last section just brings us up to the present day, or more specifically to December 2024, so just before Christmas. NICE endorsed Tirzepatide, which is Mounjaro, for use within the NHS. And if you look at the criteria, the eligibility criteria, superficially, they look very similar to the Wegovy eligibility. So essentially, again, you need to be living with obesity and you need to have any weight-related comorbidity. But there are two deceptively important changes that NICE has introduced here. Firstly, they have removed the 2-year maximum duration of treatment. And secondly, NICE no longer mandates that the treatment is prescribed in a specialist weight management service. So in theory, and I say in theory, a patient could be prescribed tirzepatide for weight loss in primary care and could receive that treatment lifelong. Next slide, please. So you may fall into one of two camps. You may, maybe one of three camps. You may be thinking, great, I can now get on and start prescribing Mounjaro for all the people I know that need it. Or you may be thinking, this is ridiculous. How are we going to be managing the demand for this treatment that is out there? Or you're somewhat confused about what this all means. And I think it isn't simple. It is more complicated, and I'll explain why. So normally with a technology appraisal, commissioners have 3 months over which to make that treatment available for the eligible population by law. But what's happened here is NHS England have intervened, and they've asked for what's called a funding variation, and that has been approved. So instead of making the treatment available to those eligible patients over 3 months, the treatment will be made available to all over the course of 12 years. And that isn't a typo. That isn't meant to say 12 months. It is genuinely 12 years. And that is, quite frankly, a ludicrous time frame. And I don't think that would be deemed in any way acceptable for any other condition if we weren't talking about obesity for such an effective treatment. And really is just an attempt to kick what is a difficult issue into the long grass. The reasons cited for that, so NHS England have cited a concern about primary care capacity, but I think all of us on this call will appreciate that the major reason for that is the cost of the medication. So what does that mean? Well, NICE have estimated that the full cohort eligible for Mounjaro is over 3 million. But NHSE's plans mean that only around 200,000 people will actually be able to access that treatment in the first 3 years, and the remaining 3 million or so will be able to access it over the course of the subsequent 9 years. So what does that mean, again, for us as GPs? Well, the first thing I will stress, and it's certainly very important for us as a specialist provider, is that specialist weight management services like the Oviva Tier 3 service are not affected by this. They carry on as they are, and we will be able to prescribe tirzepatide for people who are eligible for a Tier 3 service later this year. A lot of the uncertainty relates to that primary care cohort, who will receive the medication through those primary care models. And NHSE is due to release its commissioning guidance around that, about who the eligible cohort is and what is the models or the models that are going to be piloted in primary care. Now, that was due in January of this year. And as I say, we're expecting something any day now. So it is overdue. But what that means is, in terms of that primary care cohort, there are some pretty hefty unknowns. So we don't know what the funding will be for that primary care model. We don't know who the eligible cohort will be for that model, and we don't know what the actual service model will be. So that is some pretty major unknowns, and it's far from clear, which is why I stress that for people who do meet the criteria for referral to Tier 3 services, they carry on as they are, and that remains an appropriate route through which people can access this treatment. So, quick whistle-stop tour of the background and the NICE guidance. I'm going to move us on to things that are much clearer, and I'm going to hand you over to Shane to dig a bit deeper into the medications themselves.
Thanks, Neil. So I'm Shane Mehta, medical lead with Oviva. I'm also a practicing GP and have experience providing clinical leadership for diabetes and weight management services in my locality. So over the next 15 minutes or so, I'm going to give you an overview of the role of medications and specifically examine the evidence to support this. When we think about obesity, all of you will be familiar with the definition here on the left. BMI greater than or equal to 30. However, this doesn't recognize the complexity that comes with the disease, and it doesn't align with the latest definition that was recently published in a Lancet Commission last month. Recognizing obesity as a chronic, multifactorial systemic disease, it divides it into two phases. the preclinical stage, where the predominant finding is increase in adipose tissue, and clinical obesity, where there's apparent end organ damage. The definition you can see on the right aligns more closely with this and really recognizes the complexity that we find in patients with obesity. Obesity itself is associated with a number of conditions. It's a risk factor for cancer, only behind smoking, and we know it's one of the main drivers for type 2 diabetes. This is a particular concern for us in the UK, where in recent years we've seen a growth in type 2 diabetes under the age of 40 by over 40%. When we look at the economic modelling, we can see that the cost impact of this is clear. The cost to the NHS, both of treating diabetes and its complications, is 19 billion. That's 4% of GDP. The end effects of obesity mean it's too late for prevention alone. When we look at the other studies, next slide, please. So other studies that have looked at the impact of weight loss have clearly shown that there are cardiovascular health benefits that result from this. Even weight loss in the 5 to 10% range can lead to prevention of diabetes, improvements in cholesterol levels, and reversal of non-alcoholic fatty liver disease. When we achieve weight loss of greater than 15%, that's when we see reduction in cardiovascular mortality, type 2 diabetes remission, and reduction in heart failure. Now, until recently, there's been a lack of availability of medications to support weight loss that have had good efficacy and tolerability. This really changed with the advent of GLP-1 receptor agonists such as Wegovy, and GLP-1 and GIP receptor agonists such as Mounjaro, Tirzepatide. So what are these medications? How do they work? Well, GLP-1 is a naturally occurring incretin hormone. It's produced on the ingestion of any food, and it has a wide range of effects, but one of the main ways it works is by making you feel fuller for longer and therefore putting the brakes on hunger itself. GLP-1 receptor agonists such as Wegovy work in a very similar way to the natural GLP-1 hormones, but they bind the receptor for longer and therefore have that effect on helping patients feel fuller and supporting weight loss. Next slide. So Mounjaro is a dual GLP-1 and GIP agonist. And so what is GIP? Well, GIP is also a gut-derived incretin hormone and works in a very similar way. It's thought to enhance the GLP-1 receptor agonist effects. In fact, GIP is thought to enhance weight loss further by altering fat metabolism, enhancing insulin sensitivity, and possibly by increasing metabolic rate slightly. Next slide. So here, I won't go into this slide in lots of detail, but we've got a slight head-to-head of Wegovy, semaglutide, Mounjaro, Tirzepatide, and I just want to highlight some of the practical things with these medications. You know, they're both similar in that they're both once-weekly injections. They come in different strengths, which are predefined and pre-dosed to make it easy for patients to self-inject because they come with a pre-filled pen device that enables this for patients to inject at their convenience. They're both NICE approved, and my colleagues already talked through some of the sort of challenges with implementation of Mounjaro specifically, but both of these drugs are currently in good supply. There are no shortage protocol alerts from the National Patient Safety Alerts team on these drugs, and so they are in good supply and available for use. The efficacy of both of these drugs is graded as high, and over the next few slides, I'm going to sort of go into a deeper dive of the outcomes and the head-to-head evidence in this area. Next slide. So there are two landmark trials that we need to consider when examining the evidence for Wegovy and Mounjaro. For Wegovy, it's the STEP trial, and for Mounjaro, Tirzepatide, it's the SURMOUNT trials. The STEP trials had a 68-week endpoint, whereas the SURMOUNT trial had a 72-week endpoint. So those on the trial with Mounjaro had a few more weeks to perhaps have a little bit more weight loss as a result. When we look at step 1 specifically, what did it show? Well, at the 68-week mark, patients on average had a 14.9% average weight loss on the highest dose, Whereas in Surmount, patients were on the trial for a little bit longer, 72 weeks, and they achieved an average of 20.9% weight loss on the highest dose of tirzepatide at 15 milligrams. Now let's have a look at the graphs in front of you in a bit more detail. So I'd like you to ignore the one in the middle at the moment and just focus on the graphs on the left and the right. You'll see that both drugs, a high proportion of patients achieved greater than 5% weight loss, 86% with Wegovy, 91% with Mounjaro. When we look at the darker green bars, this is where this graph becomes really interesting. You can see for Mounjaro, over 57% of patients had over 20% weight loss, whereas for Wegovy, that's 32%. And that gives us a bit of an indication as to which drug has more effective weight loss outcomes than the other. Next slide. So unfortunately, there are no published head-to-head trials of these drugs. We had an early press release from Lilly on one such head-to-head trial just around Christmas. And you can see here, the key headline results are that it suggests that both drugs have a similar safety profile, but that tirzepatide Mounjaro has perhaps more impactful weight loss outcomes. We await the full publication of this trial later this year. So over the next few slides, I'm going to delve deeper into the Surmount trials, given that tirzepatide and Mounjaro is so topical at the moment, and I'll give you an overview of what each of these trials added to the current evidence base and what it means for us in practice. So let's look at Surmount 1. This is a landmark trial on which the key basis of evidence that was submitted to the NICE-TA came from. It was a phase 3 double-blind trial with over 2,500 adults included. Of note, patients with diabetes were excluded from this population. The key inclusion criteria was patients with a BMI of over 30, or those with a BMI of over 27 and at least one weight-related comorbidity. So what did it show? Well, if we look at the figure on the left here, we can see that participants at the end of the 72-week period for the trial on the lowest dose of tirzepatide, 5 milligrams, achieved an average of 15% weight loss. Those on 10 milligrams achieved an average of 19.5%, and those on the highest dose of tirzepatide at 15 milligrams achieved an average of 20.9% weight loss. Now, you can see that the cost difference based on the BNF costings of the different pens, there is a slightly different price as the dose gets higher, and perhaps there is a bit of a conversation to be had about how worthwhile it may be to go from 10 to 15 milligrams based on the cost difference that you can see and the outcomes achieved. What else did the trial show? Sorry, back a slide. So a few things to note about the trial itself is that 5% of participants within the trial discontinued the drug due to side effects. This compares to around 3.1. This compares, to around 2.6% in the placebo arm itself, and so limited difference there between the two. But one of the key things to note is that throughout this process, participants received intensive behavior change management support with dietetics and exercise support weekly alongside the medication. And it's through this lens that some of these results were achieved. Next slide. So then came Surmount 2. This trial focused specifically on patients with diabetes. And the idea was to monitor weight loss outcomes in a population with type 2 diabetes specifically, because they were excluded from Surmount 1. So what did it show? Well, again, you can see that approximately 80% of participants achieved at least 5% weight loss, and nearly a third of participants achieved 20% weight loss as a minimum. And nearly half of the participants achieved normal glycemia. And they used some really strict criteria for this, stricter than we might normally use, in that, less than 5.7% or less than 39 millimoles for the HbA1c. So in conclusion, the trial really shows that even in a population with type 2 diabetes, there's clinically meaningful weight loss and HbA1c improvements that are seen. Of note, the weight loss achieved is slightly less than in the non-diabetic population, and that's in line with findings from other GLP-1 trials. Next slide. So what followed is SURMOUNT-3. What did this study really aim to prove? Well, it really aimed to look at, well, if participants have already lost over 5% of their body weight through intensive lifestyle and behavior change support, is it still worth adding in a GLP-1 at this point? Does it still have a positive effect? The short answer is yes. You'll see that on average, and at the end of the 12-week behavior change support program, participants lost an average of 6.9% of their body weight. They then went on to have either Tirzepatide 10 or 15 milligrams and lost a further 18% of their weight. And of course, this could help prevent other weight-related complications as well. Next slide. So the final trial for us to take note of in this area is SURMOUNT-4. And here, what happened is that participants were given Tirzepatide for a period of 36 weeks. And you can see by then participants had on average lost 20% of their body weight. But at this point, the graph splits into two. You've got the placebo arm and those that continued having Tirzepatide. So half the participants stopped having Tirzepatide at the 36-week mark. And you can see quite clearly in that graph that there is an element of weight gain over the remainder of the trial period. In those that continued to have the active ingredient, Mounjaro, Tirzepatide, there was continued weight loss, although that plateaued, but weight loss was maintained for the remaining year. So what does it show, and what's the impact of this? Well, quite clearly, what it means in practice is that it shows that continued treatment is required to maintain weight loss. And that might explain some of the changes in the NICE-TA, where there isn't an endpoint necessarily for stopping Mounjaro specifically. So a few other points I'd just like to flag at this point is that all of the SURMOUNT trials showed a positive impact on blood pressure and lipids. However, we don't have any published studies for Mounjaro that confirm end cardiovascular outpoints. And this is in slight contrast to evidence we have for Wegovy with the publication of the SELECT trial, which clearly shows benefit in cardiovascular outcomes. Next slide. So earlier I referenced some of the cardiovascular benefits of weight loss. On this slide, you can see an infographic that summarizes the other benefits for other conditions. You can see that there is evidence for improvements in osteoarthritis with weight loss, and trials have also shown improvements in obstructive sleep apnea and asthma, for example. So wide-reaching benefits. Slide. So in summary, just some take-home messages from me. I mean, 3 key messages that I would sort of like all of us to just reflect on is that, the trial evidence really clearly shows that we have effective medicines to enhance weight loss outcomes. And we see that in practice, that their impact is beyond the obesity itself. There are much wider health-related benefits that are apparent. Most of this impact, and I think in all of these studies, it's really clear that this impact is only achieved through the lens of behavior change support. In all of these trials, patients received intensive support, both from dietetics and individualized coaching support. And it's through these lenses that we see the results achieved with these drugs. Next slide. So on this slide, you can see our clinical leadership team for our Tier 3 weight management service at Oviva. We try to mirror what's evidence-based. We have the full MDT mix to ensure we always provide care in line with the latest evidence and to achieve the optimal results for our patients. Next slide. So I'd like to leave you with a couple of case vignettes and some feedback from patients on our program. Here you can see from Hannah and David. I'll just give you a moment to look over those vignettes. You'll see that both Hannah and David report a positive experience on their journey so far. With David in particular, in the very early aspects of our program on our Tier 3 weight management service, already having lost 4.5 kilograms and looking forward to continuing that journey. So with that, I'm going to hand you over to my colleague.
Hi, Shane.
Good to see
Hi,
you.
everyone. Good afternoon. Can you hear me? This is just a sound check. Perfect.
Thanks for
Yeah,
sending it.
Ah,
yeah, we can hear you.
and welcome, everyone. So before we start, I thought it would be a good idea for each and everyone on this call to think of a personal experience of treating a patient with complex obesity. And hopefully, as I discuss some of the evidence base and the available treatment options, you can, in your own mind, formulate as to what a gold standard treatment pathway should look like for a patient with obesity. I'm more than happy for you to start off with sort of a blank slate, unlimited resources in some respects, and obviously narrow it down to a more uh, sort of a pragmatic and uh, sort of efficient and cost-effective pathway, essentially, that we can obviously deliver for our patients. Uh, First slide, please, if that's okay, Tara. So I wanted to start off by explaining about these pretty potent receptors in some respects. G protein coupled receptors, we all have it, and we are probably most familiar with GLP-1. GLP-1 is or has been around essentially for several years, at least the discovery of which. Uh, and uh, and treatments for GLP-1 agonists, treatments essentially utilizing the activation of GLP-1 have uh, certainly been around for several years, mainly in the diabetes uh, field. But we've learned a lot about them. So we've learned that they are quite potent and they are impactful in terms of metabolism, uh, especially from a weight loss perspective, and particularly when activated in combination. And I will try to explain more about this as we go along. Next slide, please, Tara. So. Uh, Before we can truly understand the efficacy of GLP-1 treatments or incretin-based treatments, if I uh, may add, I think it's important for us to understand the context of weight loss treatments and perhaps the gold standard treatment option that we have for patients with complex obesity, bariatric surgery. So in the UK, we typically tend to offer either a bypass or a sleeve for patients with complex obesity who fit NICE criteria. Typically, a sleeve is offered to patients with a lower BMI and less metabolic complications, whereas a bypass is offered to patients with a higher BMI and more complex metabolic disease, especially type 2 diabetes. Now, there is some nuance here in some respects, and certainly combination approaches and multimodal surgery can be offered to patients who are more complex. Uh, Now, these two studies which I've put on this slide reflect outcomes post-operatively. So the BIBAND sleeve study is a UK-based prospective study looking at outcomes post-sleeve and post bypass in particular. It also looked at outcomes from a band, but a band is not really offered in mainstream UK circles any longer because of a variety of problems, including with complications and lack of efficacy. So for context, a sleeve is expected to give you total weight loss of approximately 20 to 30%, and a bypass is expected to give you total weight loss of approximately 30 to 40%. Um, Now, uh, this next study by Adams et al. Essentially looked at longer-term outcomes following a Roux-en-Y gastric bypass. Now, as you can see, essentially, your total weight loss sort of occurs around the 2-year mark, and thereafter, patients tend to regain weight, but they tend to plateau around the 20% weight loss mark, which is still quite efficacious for a lot of these patients. Now, what does this mean? So we know from trial data looking at metabolic outcomes that the 15% weight loss mark appears to be key in terms of achieving metabolic improvements, if not resolution, especially with type 2 diabetes. And anything over and above that, we aren't quite clear with regards to what your long-term effects are, but we are increasingly starting to understand that such profound weight loss may be associated with other improvements, not only in metabolism, but in terms of cancer risk, as well as chronic inflammation. Um, um, Frailty is a big item on the agenda currently, especially with NHS waiting times, and there is also some evidence to suggest that weight loss in this context can be associated with improvements in frailty too. Now, just wanted to understand this. So, post-bariatric surgery, patients with metabolic disease, so for example, type 2 diabetes, obstructive sleep apnea, and high blood pressure, they can be off their treatments on day one, immediately post-operatively. And this is certainly independent of weight loss outcomes. And we think that the mechanism of action here is activation of these G protein coupled receptors, GLP-1 in particular, but also in combination, which results in these quite profound outcomes post-operatively. So let's keep this in context out of interest and discuss these incretin-based therapies based on outcomes from what we know about bariatric surgery. Next slide, Tara, please. The first agent on the market that truly made us understand and take notice of the power of these agents was semaglutide. And this was a single G, so it activates GLP-1 only. Average weight loss is approximately 15%. So as I was mentioning in the past, it has an impact with regards to your metabolic improvements. But if we have a look at the bar charts at the bottom, what I was particularly intrigued by was the fact that up to a third of the patients who went up to the top dose of semaglutide started to experience weight loss akin to bariatric surgery. And this is obviously exciting because we've never really seen this level of efficacy with non-surgical intervention previously. As you are aware, it's a once weekly injection, and it's currently NICE approved for a 2-year course. So keep that in mind as we ramp up the G-force, as we call it. Next slide, Tara, if that's okay. Double G. GLP-1 and GIP. So this is Tirzepatide. It's been on the news recently, and as you are aware, NICE have recently approved it for both diabetes as well as an obesity indication. GIP in particular is an interesting G protein coupled receptor because it also appears to have an effect on visceral fat. And this is particularly important when considering remission from metabolic outcomes. So the fat that coats your organs essentially appear to correlate with metabolic disease, certainly type 2 diabetes, and this may to a certain extent account for some of the profound improvements we are seeing with glycemic control alongside weight loss in patients who use tirzepatide. Now, again, average weight loss approaching the 20% mark, not seen before, again, with injectable treatments. And if we look at the bar charts again, you'll be able to appreciate that in up to a third of patients, you're now experiencing with injectables alone over 25% of patients. Now, again, for context, essentially, with bariatric surgery, we would expect between sort of 30 and 60% of patients to achieve these levels of weight loss. So not quite up to the standard of surgery just yet, but again, very encouraging. Nice approved for obesity, and the difference from semaglutide is that there isn't necessarily a 2-year cutoff for these patients. Next slide, please, Tara. Now, we're going to ramp up the G-force even further. Retatrutide also activates glucagon alongside GLP-1 and GIP. And this is the first time I think I've seen bariatric surgeons sort of slightly squirm in their seat because we are starting to see essentially average weight loss in bariatric surgery territory, up to 25%. So there is a good chance that for a select group of patients who may otherwise be referred for a sleeve gastrectomy, there is the option now of an injectable agent to sort of not only achieve but also hopefully sustain weight loss long term. And again, essentially, if we look at the columns expressing over 30% weight loss, i.e. bypass territory in some respects, we're seeing this in up to a third of agents, not seen before, obviously, with incretin-based therapies. So this is currently in sort of phase 3 trials. We haven't fully understood what the dosing is, but it is again going to be a likely weekly injection. And the understanding is that it should be available in the next 18 months or so for use. That's at least what I've heard, but we will see. Right, next slide, please, Tara, if that's okay. So the key question here is bariatric surgery still needed? And the answer is a categorical yes. I think we need to understand that patients with complex obesity are likely to require multimodal therapy, and sort of obesity should certainly be considered as a lifelong disease. And the way I think about it here is that we now have the option of introducing agents at various time points in their treatment course. And certainly in our own NHS practice, we are typically pre-treating patients with GLP-1 agonist, helping them to not only lose weight, but to achieve other pleiotropic effects, essentially, prior to considering bariatric surgery. Now, the issue with bariatric surgery as well, which I probably showed in my first slide, is that there is a risk of weight regain in a certain cohort of patients after around the 24-month mark. And there was a recent sort of, if so, consensus paper which also suggested that in patients that do regain weight, we can use GLP-1 in order to sort of maintain weight loss or even induce further weight loss in a cohort of patients, potentially avoiding the need for a second surgical procedure. We also must be mindful that weight loss with GLP-1 agonists can take some time. So for potentially a sort of quicker process, such as organ transplantation or cancer, a surgical procedure may still be needed. Next slide, Tara. So I thought I'd just very quickly mention about titration tips, especially with tirzepatide. Now, I'm sure that primary care have gotten their hands on tirzepatide for patients with complex diabetes. And I would like to emphasize that we are in a sort of phase of care where an acceptable HbA1c is no longer acceptable. So what do I mean by that? So typically we say, okay, fair enough, as long as we're able to aim for HbA1c of around in the 50s, so above 48 that constitutes good diabetic control. But we are increasingly starting to see that in patients who are commenced on tirzepatide, we can now aim for an HbA1c that's completely in the normal range. So at levels certainly mimicking remission. Now, I agree these patients have to remain on tirzepatide long term, most likely, but our treatment targets should certainly be escalated in this context. And that also means that we should no longer be thinking of this condition with a purely glucose-centric focus. And I think that's sort of a key take-home message in this context. Managing side effects. Typically, gastrointestinal side effects are very common, usually very mild, and can be managed with over-the-counter supplements. Nausea in particular can be managed with sort of as required on Lancetron if required. And there's some anecdotal data to suggest that things like Diet Coke, for example, and other fizzy drink, 0-calorie preparations can also help to alleviate some of these side effects. Next slide, please, Tara. So the future, tempered excitement. So I think we all get excited by treatments that we can offer our patients, especially with complex disease. I think we are increasingly starting to understand as to where these incretin-based therapies sit in the hierarchy of treatments for complex obesity. Bariatric surgery is still by all means gold standard, but we now have options that are theoretically, at least, more easily accessible and non-surgical. And I anticipate that a significant proportion of our patients are going to benefit from these drugs long term. Other benefits, we are increasingly also starting to understand, as Shane mentioned on one of his last slides, that there are pleiotropic effects of GLP-1 agonists, and perhaps this is something we can discuss at a future webinar in some respects. But exciting times, and I think these drugs can certainly be utilized for a variety of disorders moving forward. I think that's the end, isn't it, Tara? Or do I have another slide? Fine. Happy to take any questions. Thank you.
Thanks, Wasim. That was great, and thank you, Shane, as well. We are running a bit over, but I'm just going to finish with a couple of slides, and then we'll probably have time for maybe one question or two at the end. So next slide, please, Tara. Yeah. So we've talked a lot about the how effective these treatments are. We've also talked about that shortfall in access to tier 3 weight management services. So I just wanted to, I'm sure many people on this call already know this, but just to flag that Oviva's service, tier 3 service, is now available to patients across England through Right to Choose or Patient Choice. So what do we mean by that? Well, as I'm sure many are familiar with, patients in England have a legal right under the NHS Constitution to choose which provider delivers their consultant-led specialist care. And that doesn't have to necessarily be the provider that is geographically closest to them. And I think we are very familiar with that when it comes to common surgical procedures, things like cataracts, hernias, hip replacements. But it applies equally to consultant endocrinologist-led specialist weight management treatment. So what that means is that if a patient is deemed eligible for referral to a tier 3 weight management service with their GP, that patient can choose to be referred to Oviva's service. And because we are a remote provider, we can support people living in any part of the country. So, it's a hugely exciting development, and it's a route through which we're playing our part to tackle that shortfall in access to specialist weight management services, and ultimately to make these treatments, these very effective treatments that we've just heard about, available to the people who stand to benefit from them. And there's a question, I think, in the Q&A about some of the practicalities around that. But one of the advantages we have as a remote provider is, as I say, one of the many advantages is that we can support people living in any part of the country. We can also have a workforce that covers the whole of the country. So we are able to see people much more quickly than traditional services where we know there are very long waits. In one of the areas that we've been working with, patients have been waiting 4 years on the waiting list for a tier 3 service, which clearly is not vaguely acceptable. Next slide, please. Brief outline here about how to refer. It's very simple. Essentially, complete the referral form, which you can find at aviva.com/refer, and send it in through the usual channels, either through NHS Mail or through ERS. And then, because we're already 5 minutes over, but I thought we'll just take a couple of questions. So we had a couple of questions come in advance. One question that came in that we get quite a lot, and I don't know, Shane or Wasim, if you want to take this. We see a lot of young women in our service, and one of the questions that always comes up is, what is the implications around these medications? First, around conception. So firstly, in terms of just general preconception counselling, and then I think secondary, in terms of people who are on hormonal contraception, what is the approach with these medications? Wasim or Shane, I'm not sure who wants to take that.
I'm happy to take that. So this is a very interesting question, right? And I think I mentioned in my slide earlier on as well about some of the potential impacts on fertility. There's emerging evidence that these drugs can make women previously deemed subfertile because of insulin resistant very fertile. And this is sort of akin to what happens post-operatively. So patients immediately post-bariatric surgery become super fertile in some respects, and we often have to counsel them about this as well. Now, the bottom line is that we don't yet have enough data to support the use of these drugs as a fertility agent. But the typical manufacturer advice is that these patients should be taken off GLP-1 agonists at least 3 months before planned conception. Now, if a woman was to conceive whilst on these treatments, the overall risk profile appears quite low, and I typically tend to advise them just to let us know if that's okay and simply discontinue the drug. Whilst on treatments, as I said, given the lack of evidence, we've got to counsel these patients regarding the use of contraception, and that leads me on to the efficacy of sort of some of the oral contraceptive agents. And again, here the sort of general consensus is that there is a possibility that patients on the oral contraceptive pill can potentially have it can potentially be less effective. But I think we probably need sort of a bit more data in this context to be more categorical about that. So I generally tend to counsel these patients to ensure that yes, you can use contraception essentially, but if you want to be extra sure, then please use barrier contraception alongside this. As I said, fertility can be enhanced quite significantly on these drugs.
Thanks for saying. That's a very nuanced answer, and obviously, not a straightforward picture. Just to note, there are a few questions that have come in on the Q&A that are more related to commissioning issues, which we're not going to tackle in this webinar, which is focused on clinical matters, but we will respond to people who've raised those more commissioning-related matters. I'm just going to finish with one other question, and probably going to you, Wasim, because it came up in the last webinar, and it's come in a question in advance, which is similarly around management of anticoagulants and what the implications are for people on different anticoagulants as well as these medications.
So this again is a very interesting question, and I probably have to change my answer slightly from when I commented the last time around. So there are a couple of layers to this answer. The first is, well, for patients who require anticoagulation, you've got two options. You've either got DOACs or you've got the option of warfarin. And the sort of consensus was that in patients with significant obesity, so historically a BMI of above 40 and or a weight of above 120 kilograms, essentially, DOACs were discouraged because these patients weren't included in their efficacy outcome studies. Now, uh, there was a relatively recent systematic review looking at the outcomes of patients with complex obesity, which seemed to suggest, you know what, their efficacy is probably not is not reduced that significantly. But we must be mindful that the studies that were looked at in this meta-analysis, in some respects, essentially were small scale and did not necessarily include patients with uh, sort of significant obesity, i.e., BMI above 55. So I think the general consensus currently is that certainly if you've got obesity and if you require anticoagulation, then uh, it's a very individualized risk-benefit discussion in this context, and I would certainly involve a hematologist to make sure that treatment decisions factor in obesity as a potential, as having a potential impact on the efficacy of these drugs. The second layer of this is sort of monitoring of INR and warfarin, etc., and so on. Uh, Now, the general consensus appears to be that there probably isn't much of an effect in terms of INR, but I think manufacturer guidance essentially suggests that that because of gut transit issues associated with incretin-based therapies, it is probably best practice to make sure that sort of INR monitoring is sort of escalated to a certain extent, or at least their sort of INR monitoring service is informed that these patients are on these drugs, simply to uh, make sure that their dosing is appropriate in this context. I think this sort of I think in general, what I'm starting to advise patients, or at least patients with complex diseases, is that if you're on a drug that has got a narrow therapeutic window, even though there isn't a significant evidence base out there just yet, regarding whether or not these drugs impact on these levels, it is probably best practice for these drugs to be monitored just to ensure that they are being they're having an appropriate effect in this context.
Thanks, Wasim. Yeah, and again, really nuanced answer, really helpful, and I think just reflects, that we are all still learning about these agents in terms of their use for complex obesity. Look, we're about 10 minutes or so over, but I think it's been really useful to have those a few questions at the end there. As I said, apologies to those who've asked questions that we haven't got back to. We're happy to get back to people in writing. Just want to thank Shane and Wasim again, and thank everyone again for sparing the time this afternoon. I hope people have found it informative, and ultimately, I hope people have come away with at least a few things that they're going to take forward into their consultations with patients. Okay, take care, everyone. Thank you.